First and foremost, I would like to thank all of you who have joined in here and Dr. Ram Gopal Krishnan, who has agreed to be a faculty or a speaker for this program. One small announcement, we have our 12th annual conference of the Clinical Infectious Disease Society in Calcutta on 14th to 17th of July. We would encourage all the postgraduates to submit abstracts and also to attend the conference. I'm sure it's going to be a very good academic feast. I would now pass over the thing to Nitin, and Nitin will go ahead. Thank you.
Hello and good evening to all. On behalf of Clinical Infectious Disease Society and its PG Education Subcommittee, I welcome you all for the second ID Masterclass. Infectious disease is a subspecialty under internal medicine, and our society, which has been active for the last 12 years, have been working together to educate practicing physicians and doctors to better manage infections in their patients. Now, SIDS has taken one more step forward. We have formed a PG Education Subcommittee to involve postgraduate students and help them to learn and manage their patients with infections. We had done our first webinar, rather ID Masterclass, in the month of March, second week of March, which was received with great success with over 250 attendees. We intend to repeat the same in subsequent months. We plan to make this ID Masterclass once in every month in the second week of the month. And to introduce our members, I would like to welcome Dr. Senthil Nambi from Chennai. He is the chairperson of our subcommittee. Dr. Vidya Devarajan, also from Chennai. He is the secretary of the subcommittee. Dr. Satya from Kolkata. Dr. Sayan from Kolkata, Dr. Arvind from Kerala, Dr. Neha from Bangalore, and myself, Nitin from Delhi. We are all the members of subcommittee, and we are all practicing infectious disease physicians in our respective places. Before I begin, I would like to request you all to please keep your devices in mute mode, and you can type in your comments and questions in the chat box. We will try to take them after the end of the session. We also have an interesting quiz session after the webinar. So please stay tuned and please make your attempts to win. And there are attractive prizes to be won. So moving forward, I would like to introduce the speaker. It is my privilege to, and actually an honor to welcome Dr. Ram Gopal Krishnan sir. He is my teacher, my mentor, and he did his MD from prestigious PGM Chandigarh. He is an American board certified in both internal medicine and infectious diseases. He is also certified in tropical medicine by American Society of Tropical Medicine and Hygiene. He is a fellow of Infectious Disease Society of America and its European counterpart, ECMID. He is an adjunct professor in Tamil Nadu, Dr. MGR Medical University. He is the past president of our society, SIDS. He is the chairperson of the antimicrobial guideline written by ICMR. He has published more than 80 articles, 9 chapters in various books, and more than 250 invited lectures. I can go on and on by reading his CV, but actually he's a great teacher and he's a person who has mentored batches of ID physicians, and he's someone who we always look up to or aspire to become like him. It is always a great pleasure listening to him, and we still keep learning from him. So I would like to invite you, sir, and hand over the mic to take the session forward, sir.
Thank you, Nitin, for that generous introduction. Give me a minute while I share my screen.
Sure.
Okay, hope my slides are visible to all.
Yes, sir. They are visible.
Okay, so this is the topic which SIDS has assigned to me today, approach to pneumonia. And it's obviously a huge topic. So what I'll try to discuss in the next 30 minutes or so is try to answer these following questions. When you're in practice, when somebody comes with cough, is it pneumonia or is it bronchitis? Will you admit this patient? What tests will you do and what antibiotic will you start? Will you do something different if the patient is admitted either to the ward or the ICU? I'm going to assume that all the patients we are discussing, all the scenarios we're discussing are in COVID negative patients. And so we will take that for granted. And in terms of references, there are just two main references which I would point you to. the most recent iteration of the IDSA ATS guideline, which is fairly recent, and the ICMR guidelines, which is also fairly recent, if you want to consult this document for further information. So this is a typical case scenario. 46-year-old male, previously good health, has a 4-day history of productive cough and fever and shows up in your OPD. Your saturation is 98%. So the first question you need to ask is, does this patient have pneumonia or acute bronchitis? It makes a big difference in the way you manage this patient. And so what have we had conventionally all these years? We have had history and physical exam, and we have a chest X-ray. These are the tools of our trade. Are they as reliable as we think they are? Let's see. Now, there's an older study more than 20 years ago, which looked at 50 patients in whom they did an X-ray, but they hid the X-ray from so-called expert physicians and asked them to clinically diagnose. In other words, look for bronchial breathing, look for other signs of consolidation. They found that the experts picked up only about 60% of pneumonias. And the specificity was somewhat better. In other words, if you heard, say, bronchial breathing, you're a little more likely to get that right. So you can see that a large percentage of the time, experts can actually miss the diagnosis when you don't do an X-ray. A more recent study showed that chest X-rays pick up pneumonia roughly in about 1 in 6 patients who come with acute cough to your outpatient. And what predicts the presence of pneumonia? Certainly, if that patient's saturation is going down or the heart rate is going up, or if you actually hear crackles on auscultation. So the take-home point is, please do an X-ray on all patients before ruling out a pneumonia. And if you hear positive findings, yes, chances are that it's a pneumonia. But if you don't, you may be missing a pneumonia. Pay close attention to vital sign derangement, which will provide a clue to the diagnosis. Don't worry too much about the sputum color. In that study, 28,000 patients, the color of the sputum, whether it's green or yellow or white, did not really predict whether it was bronchitis or pneumonia. And sometimes you might have to end up doing a CT to rule out pneumonia. Obviously, we wouldn't do that in practice, but just to tell you that even X-rays may miss the diagnosis. So this patient whom we discussed, you've been good, you've followed the guidelines, you've gotten an X-ray, and there are right-sided crackles, so we're clearly dealing with a pneumonia. So the first question you need to answer is, will you treat this patient as an outpatient or will you admit? Now, there are many so-called pneumonia scores that you can look at to try to determine this. The one that comes to the tongue most easily is the CURB 65, for no good reason other than that it's easy to pronounce, that's all. Basically, if you're elderly and if you have vital sign derangement, chances are you will need admission. Higher the number on that score, greater the indication for admission. The most comprehensive pneumonia scoring index classifies pneumonia into risk classes 1 to 4. It's too complicated, but if you just casually look at it, anybody with vital sign derangement, anybody with lots of underlying diseases clearly would have a higher score and therefore would end up in the hospital. So you certainly don't need to remember these scores, except that know the risk factors that predict a higher score. And there's one with a very smart and catchy mnemonym, SMART COP. Again, it's just putting together what we know as clinicians. Somebody has deranged vital signs, lots of comorbidities, then that patient is likely to need hospitalization, etc. So you can use any one of these scores or just trust your clinical judgment when you decide to put patients in the hospital or treat them as an outpatient. So the particular patient that we discussed, you decide to treat as an outpatient because vital signs are not deranged and the saturation is good. So first of all, will you do any tests for this patient with pneumonia? So these are the potential tests available to you in practice. Are any of these tests useful or actually recommended when somebody walks into your outpatient and you're treating as an outpatient? So in a patient with pneumonia, we said always get a chest X-ray. That one's taken for granted. Pulse oximeter is essential. It's probably more useful than your stethoscope in this day and age, especially in the COVID era. And the bottom line is don't test outpatients. Blood cultures, not recommended. This is the IDSA recommendation. Again, sputum culture, not recommended. And what's the reason for it? Don't you want to know what is causing that pneumonia? Well, not really, and we'll see why. There's another test which is really asking for a disease. This test, procalcitonin, is widely used in critical illness in a decision, usually to stop antibiotics. It's not very useful to decide whether to start, but it's perhaps useful to decide when to stop. How has this particular biomarker done in lower respiratory tract infection. This was a trial published 3 years ago where they made this test available to emergency physicians and asked them to decide, will they give antibiotics or won't they, based upon the procalcitonin level, and it did not result in less use of antibiotics than the usual care. So it didn't really make a difference to the way emergency doctors looked after physicians. And when they put together all the studies on the role of procalcitonin, you can see here that the sensitivity is quite low, just about 50%. Specificity is not particularly high either. So procalcitonin level, really, there's no current role for pneumonia. It can't tell you whether it's bacterial or viral reliably. It can't tell you whether you need to give an antibiotic or not, which is really what you want as a treating clinician to a patient in front of you. Now, we will discuss why other tests are not needed when we go through the same patient. Now, the same patient, decide what you want to treat this patient with, and we'll come back and decide what tests you need. So what is the optimum antibiotic therapy for an outpatient with pneumonia? Doesn't need admission. So these are some of the common antibiotics you would have at your disposal in clinical practice. And let's see what is right and what is wrong here. So when you pick an antibiotic, you need to know what you're treating. And that depends on the syndrome. If this is a pneumonia syndrome, you need to know what is causing that pneumonia. And you need to see which antibiotics work and which antibiotics won't. So as a corollary, if you can predict what antibiotic you're going to deal with or what organism you're going to deal with and predict what is going to be sensitive, you don't need to do tests like sputum cultures or blood cultures to determine that. You can go by what the literature, your country, or the textbook says. So if you look at etiologies of community-acquired pneumonia in the outpatient, by and large, it's either pneumococcus or it's respiratory viruses. Occasionally, you will see one of these so-called atypical pneumonia pathogens, where the symptoms outweigh the signs and the severity on physical exam outweighs how sick the patient is. So these are typical causes of pneumonia in the outpatient. And if you say pneumonia is number one caused by the pneumococcus, the next question you need to ask is, does penicillin work against the pneumococcus? Because if it does, just use penicillin. If it doesn't, you need to use something else. So the study that answered this was this multi-center study conducted all over India. We need to see what is going on in our country. And the bottom line is penicillin resistance is very low. So it turns out that most patients with invasive pneumococcal disease are sensitive to penicillin. Notably, cotrimoxazole resistance was very high, 45% in the first decade of this century. Note that this is cotrimoxazole resistance. It's really very high, even more than 10, 14 years ago. At that point, erythromycin as well as penicillin resistance was quite low. And you can see that this study about 3-4 years later showed that there was increasing resistance to erythromycin. This is very important in clinical practice. Penicillin resistance remained low. And this study about 5 years later shows that blue is good here. Blue means a big blue bar means it's sensitive. You can see cephalosporins work well, penicillins work well, chloramphenicol, well, we wouldn't use that drug, but it would work well. But you can see that macrolides like erythromycin are falling off. This is in children, multi-center study done all over the country. You can see the rise of macrolide resistance in pneumococcus. And you can see that erythromycin, the take-home point, more and more resistance, cotrimoxazole, fairly useless for pneumonia. So this is the major issue in India. If you're treating pneumonia as an outpatient, then don't rely on a macrolide to get rid of your pneumococcus. There is increasing resistance in India. Penicillin, cephalosporins, no problem. And just to summarize, pneumococcus is penicillin sensitive. Be careful about using macrolides. Cotrimoxazole, not worth the paper it's printed on in terms of pneumonia. So when you have this kind of knowledge, you know what's causing pneumonia, and it's largely pneumococcus in young, healthy patients, community-acquired patients, and you know these patients don't have risk factors for MRSA, Pseudomonas, etc. You start off with a simple antibiotic. If they don't have comorbidities, just amoxicillin or macrolide, if your pneumococcal resistance rate is very low, which it is not in India. So you're probably better off with these two choices. With comorbidities, you combine these two, as we'll discuss. So this is the regimen for a young, healthy person with pneumonia. You focus on the pneumococcus. You focus on the atypicals, that's fine. If you're worried about that, macrolides, if you have low resistance, not always the case in India. On the other hand, if you have an elderly patient, a diabetic, heart failure, etc., you really need to cover a little bit more than this. You include H flu coverage, Moraxella, Staph aureus, and perhaps sensitive gram-negative bacilli, as well as something for atypicals. So you usually end up using a combination of a beta-lactam, like say amoxicillin clavulanate, or a cephalosporin, along with a macrolide or doxycycline. The so-called conventional double coverage approach is entirely appropriate for patients with underlying comorbidities. A monotherapy is there in the guidelines, but this may not be such a good idea in India. And this is the reason. India is a TB endemic country. And you can never be 100% sure that X-ray I showed you could well be TB, especially when the history is more than 7 days. Quinolones are not good for TB. They just postpone the diagnosis of TB and they predispose to quinolone-resistant TB. So avoid fluoroquinolones for treatment of community-acquired pneumonia. We have other options, and you may actually miss and mask TB. And this is what the ICMR guidelines say, quite similar to what the IDSA guidelines. If you have an outpatient without comorbidities, comoxiclav is preferred. With comorbidities, combine a beta-lactam and a so-called atypical coverage agent. So guidelines are generally concordant with this. The ICMR guideline also notes the high prevalence of macrolide resistance. Do not use this drug as monotherapy for pneumococcus in India. Now, what if you have somebody, say with the same X-ray, 80 years old, this patient's saturation is borderline, right? There are crackles, infiltrate is there, saturation is borderline. You decide to admit this patient, right? So this is community-acquired pneumonia, admitted to the ward. What are the tests that you would order, right? Sputum culture, not recommended. Blood culture, not recommended. Urine pneumococcal antigen, not usually needed. Legionella antigen, not routinely recommended. Now, we are not even doing these tests for admitted patients now, let alone outpatients. So in outpatients, none of these tests are needed because you can reliably say it's going to be a pneumococcus or something that you can't diagnose, like an atypical pathogen. Whatever you use empirically will cover it. And so these are the causes for community-acquired pneumonia. Largely similar to what we said about pneumonia in the outpatient. Respiratory viruses are prominent. Some patients, especially with neurological disease or elderly patients, are prone to aspiration pneumonia. And there are some recent changes in the way we are looking at pneumonia in admitted patients. For instance, this large study in the NEJM basically said that if you have hospital pneumonia requiring hospitalization, you're going to pick up either a virus or you're going to pick up pneumococcus. Remember, you only pick up pathogens in about a third of patients. It's not easy to diagnose the cause of community-acquired pneumonia. And when you do, it's going to be pneumococcus or virus. Note the relative lack of atypical pathogens in this fairly recent study. And this is a nice pictorial telling you that perhaps pneumococcus is on the decline. This is about 100 years ago when we said all pneumonia was caused by pneumococcus. Look at more recent studies, even before the introduction of conjugate pneumococcal vaccines, say in the 90s or so. Pneumococcus as a cause of pneumonia may be coming down. Certainly in developed countries, it is clearly coming down. It's not exactly clear why. Perhaps people are smoking less. Perhaps we're diagnosing virus more. And also perhaps organisms like, say, Strep milleri, Strep mitis, Strep anginosus, which are normal respiratory flora, cause pneumonia. These are difficult, fastidious bacteria. You don't often culture them or you dismiss them as respiratory pathogens. Regardless, pneumococcus is causing less and less pneumonia compared to, say, 100 years ago. So the next question is, do you need to test the sputum on these patients? Well, by and large, if you're young and healthy, you're not at risk for MRSA or Pseudomonas. Certainly for a ward pneumonia, you don't need coverage for those two agents. So unless they've had infection or some special circumstance, and is either Staph or Pseudomonas, blood cultures, you may pick up pneumococcus or Staph aureus. We know that already. We know that patients get infected with these pathogens. So at the time of admission to the hospital, you don't routinely need cultures. You don't need sputum cultures, and you need blood cultures even less and less. Only in certain indications, ICU pneumonia, severe pneumonia, or for some reason, you are using broad spectrum coverage. It's used more as a de-escalation tool to help you use a narrow spectrum agents. Or if you have what we used to call HCAP, healthcare associated pneumonia, that classification is no longer there. Somebody who's admitted to the hospital, etc. What about these antigen tests? They're not readily available in most parts of India, but they are useful because they're very specific. They're not very sensitive, but they're quite specific for the diagnosis. So in general, we don't do them unless there is some outbreak or epidemiological reason to order these tests. So as you can see, pneumonia in the ward is really quite a simple thing. Just treat the patient, assess severity, treat the patient. But there are some clinical things you can do. In terms of practicality, what do you need to determine? Is this bacterium or virus? And this is not very difficult also. We know these things. Somebody has a high white count. Somebody has a lobar unilateral consolidation. Somebody has no upper respiratory symptoms. That's going to be your classical pneumococcal lobar pneumonia. Similarly, if you have exposure to sick contacts, we're very used to taking this history in the COVID era, upper respiratory symptoms, etc., or a low PCT. Don't hang your hat on that. But yes, it may support a diagnosis of a viral pneumonia. And there are some other things you can always ask for. Is there a history of smoking, weight loss? Whenever symptomatology goes on for more than 10 days, please think TB, or perhaps endobronchial obstruction. Try to decide, are there risk factors for aspiration, usually fairly obvious in terms that the host usually has neurological issues or problems with swallowing. Okay, so how are you going to treat this patient? You admitted to this patient to the ward. What is the antibiotic you will pick? These are commonly available antibiotics. All can be used parenterally. These are some of the choices which are available to us. So what would you pick? This is what the guidelines recommend. The guidelines say that for all admitted patients, you do combination therapy, beta-lactam, something simple, ampicillin, sulbactam, amoxicillin, clavulanate, along with a macrolide. Okay, combination therapy, or beta-lactam with doxycycline. So beta-lactam plus macrolide or beta-lactam plus doxycycline. The monotherapy option is really not appropriate for India. We discussed about the issue with TB. What about beta-lactam monotherapy? We keep saying that pneumonia is largely becoming either pneumococcal or viral. So if you get rid of the beta-lactam, yes, monotherapy is okay. The guidelines say this is also acceptable. It's most important that you get a good beta-lactam on board, non-inferior in some studies to combination therapy. Mortality was as good in some studies. Once again, a large paper in the New England Journal where they clearly showed that beta-lactams alone are as good as beta-lactams plus macrolide, as good as quinolone for non-severe inpatient pneumonia. So what does this tell you? You give good pneumococcal coverage and the rest of it takes care of itself. Often it's a virus. Often whatever you use for the pneumococcus will cover the other bacterial pathogens in there. So pneumococcal coverage is really what is critical in this day and age. We spoke about the Indian situation. Don't use quinolones either for combination or as monotherapy. And this is what the ICMR guidelines say. If you're in the ward with a pneumonia, a very common situation, say ceftriaxone with macrolide or doxycycline, you could use amoxicillin clavulanate instead as well. So the guidelines are largely concordant in what they tell us to do. Now, if you start somebody on intravenous therapy, you want to do that initially, you're not sure about absorption, you're not sure how sick they are, try to switch to oral. Use a drug with a similar spectrum because this facilitates early discharge. And how long do you need to treat a pneumonia? Obviously, the guidelines use complicated terminology, but patients should look better, should be walking around, should be afebrile, saturation should be good. A minimum of 5 days. How did they arrive at that magic number? There are actually a lot of studies on this. The treatment of pneumonia is getting shorter and shorter. 5 days is good enough, 6 days is good enough, 7 days is good enough. So shorter appears to be sweeter in the current day and age. So please don't hesitate to use short duration therapy. It turns out that the first couple of doses are probably good enough to kill pneumococcus, which is usually exquisitely antibiotic sensitive. Now, there are some situations where you would have to use prolonged therapy. For instance, you have infection elsewhere, endocarditis, deep-seated infections. If you're treating pseudomyelin, that strictly follow the pseudomyelin guideline. Proven resistant organisms, MRSA, ESBL, Pseudomonas, the rare patients, please treat them longer. It's not 5 days. Now, severe community-acquired pneumonia is a subset of community-acquired pneumonia where there's genuinely an increased mortality. These patients usually end up in the ICU. Remember, pneumococcus is a virulent pathogen. Just because it's sensitive doesn't mean it's not virulent. And so how will you decide which patient ends up in the ICU and how your antibiotics will change in the more severe forms of pneumonia? Again, this is not difficult at all. Somebody's on the ventilator, they obviously need to be in the ICU. Somebody's in septic shock, they need to be in the ICU. And any vital sign derangement, marked derangement of coagulation parameters, anybody who looks septic, hypothermic, etc., obviously has a severe pneumonia. The etiology of severe pneumonia, that changes somewhat. Other than pneumococcus, consider staphylococcus and by extension, MRSA, Legionella, gram-negatives, including sometimes ESBLs, as well as Pseudomonas need coverage here as well. So these are some of the target pathogens you would have to work on in the very sick patient with pneumonia, because the consequences of missing the correct organism are higher here. Remember, look for these risk factors for Pseudomonas, underlying bronchiectasis, repeated antibiotic use, COPD requiring steroids, etc. So this is a patient with severe pneumonia who we had a few years ago. You can see that the pneumonia got worse under our eyes. When you did a CT scan, you can see these impressive lobar consolidations with these air bronchograms here. And this patient grew MRSA in the blood. So this was MRSA pneumonia actually complicating community-acquired influenza. And this patient got started on vancomycin, but the trough levels were low, finally required high-dose vancomycin to get better and got discharged. So MRSA pneumonia with its any staphylococcal pneumonia and especially MRSA pneumonia, please think of in any ICU patient. Remember, if you have pneumatoceles, that's a classic presentation, usually seen in a child. So anytime you have pleural space involvement, pneumatocele formation, staph aureus should pass through your mind. And this Lancet paper actually gives you some risk factors where you specifically consider MRSA as an etiology of pneumonia. If they've had previous MRSA colonization or infection, recurrent skin infections, but just any bad pneumonia which puts you in the ICU, please at least initially consider MRSA coverage or you will be in trouble. The usual beta-lactam will take care of MSSA, but not MRSA. Now, we are all practicing in India, so never follow Western guidelines verbatim. These are some bugs which are unique to our practice situation. We have an outbreak, or we have the highest rates of ESBLs in perhaps the world. So this is something you need to cover. Usually the broad spectrum beta-lactam you use would cover these. Scrub typhus has to be covered in India. Leptospirosis, perhaps less frequent than it used to be. And Burkholderia pseudomyelin, very, very important treatable cause of pneumonia. This is a patient with scrub typhus who had very bad ARDS. Always open the patient, open the bed sheets, look from top to bottom. There is no side. Typically, the flexural surfaces, typically the genitalia, will show you this lesion, which is virtually pathognomonic of scrub typhus. Pseudomyelin is an important pathogen. It may cause abscesses elsewhere. This patient had bad lung abscesses, necrotizing pneumonia, got better after therapy. And so if you're in the ICU, you certainly need blood cultures, at least 2 sets, because say picking up MRSA, picking up Burkholderia pseudomyelin, you really need those blood cultures, and doing other tests for say pneumococcus, Legionella is appropriate. If you're tubed, you have a nice sample presented to you. Please send that as early as possible so as not to reflect subsequent colonization in the hospital later. And so if you have a healthy young patient who ends up in the ICU, usually that's a pneumococcus. So beta-lactam plus a macrolide is good enough. They don't usually have risk factors for MRSA or Pseudomonas unless perhaps they have a preceding influenza-like illness. That is the approach recommended. But more often, we have this older patient, lots of comorbidities, underlying diseases, perhaps some antibiotic exposure, as an outpatient. So you have to broaden the spectrum in these severely ill patients. You need anti-pseudomonal beta-lactam. Any of these choices are appropriate. Often you'll have to add either linezolid or clindamycin to shut off toxin production as well as give you coverage for MRSA, plus atypical agent coverage. Classically, the drug we use is azithromycin, which seems to have an immunomodulatory effect and may reduce mortality in bacteremic pneumococcal pneumonia. It works well against scrub typhus, which is an important pathogen in our country. But you could do clarithromycin, you could do doxycycline. Both are entirely appropriate. Perhaps there is less of an issue with QTc prolongation and sudden death when you use doxycycline in sick patients, elderly patients. And this particular study clearly said that routine MRSA therapy is not needed. So reserve MRSA therapy for patients who are severely ill or who have risk factors I told you about, previous MRSA infections or soft tissue infections, and always make an attempt to de-escalate. If you start off broad spectrum, if you don't grow any resistant pathogens, switch back to your classic pneumococcal coverage. This is important. And this is what the ICMR guidelines say as well. Inpatient in the ICU without comorbidity, ceftriaxone with macrolide, in the ICU with risk factors for gram-negatives, say Pip/TAZ along with macrolide or doxycycline. So quite similar to the ATS IDSA guidelines. Do you need anaerobic cover? This is not routinely recommended. The main reason for this is the current concept of aspiration pneumonia is that it's largely caused by what is there in the patient's throat, usually pneumococcus or sometimes a gram-negative rather than anaerobes. And the standard beta-lactams would take care of all anaerobes above the diaphragm. B. fragilis is not a consideration here. So you don't need routine anaerobic coverage. Now, in 30 minutes, it's difficult to do justice to pneumonias in other hosts, but you will often see this in practice, and these are challenging hosts, pneumonia in the immune-compromised host. So in this situation, classify the immune defect. If it's a, say, solid organ transplant recipient or a HIV patient, T-cell immunocompromise is there. If there is chemotherapy following, if there is neutropenia following chemotherapy, that's a different host. So classify the immune defect. That's very important. In, for instance, a solid organ transplant recipient, these are classical pathogens which are eliminated by T-cell immunity. So always consider TB, nocardia, aspergillus, and pneumocystis. And often these patients would require an early bronchoscopy to make the diagnosis. This is a patient we had who grew CR E. coli in the blood, solid organ transplant recipient, along with culture-confirmed necrotizing pneumonia due to mucormycosis. So you can see that these patients can be quite challenging to diagnose. In the HIV positive host, there's usually a triple differential. It's usually pneumocystis versus tuberculosis versus pneumococcus. If the CD4 count is low, obviously that would make pneumocystis more likely. The radiology is very important. Anybody with a bilateral symmetric, you could say almost a COVID type X-ray has pneumocystis. These GGOs are fairly typical for pneumocystis in a HIV positive host. So this kind of radiology can help you make a differential. On the other hand, in a neutropenic host, the causative organism is usually Aspergillus. You have a galactomannan test available to you. CT scans are very useful. We often proceed straight to CTs. We don't waste time with X-rays in neutropenic hosts because CTs are much more sensitive. Look for this halo, this so-called angio invasion just outside the actual infiltrate, which is a sign that this is probably a fungal infection. And this is too late. If you see a patient in advanced stages, they will often cavitate out. So this is my last slide, pneumococcus and virus. So if you're actually rethinking concepts of pneumonia, is it viral or is it pneumococcus? Sputum testing has gone out of the window. You almost never need it except in the ICU, where hopefully you would have an endotracheal tube from where you can get the secretions off. In India, some specific pathogens, always keep in mind, community-acquired MRSA, scrub typhus, and melioidosis. The general working rule is beta-lactam plus macrolide for most patients, but you're certainly not doing anything wrong there is increasing evidence that just good pneumococcal or beta-lactam coverage is enough. Thank you very much. I will stop here and stop sharing. And I'll hand this over to Nitin and Vidya to take this forward.
Thank you, sir. Thank you for the wonderful lecture. I would like to start with the question session, if you allow so, sir.
Sure.
I have plenty of questions to provide you. So there are 3 questions regarding Staph aureus. I think I will read the 3 and then you can club the answer. How much percentage of CAP is generally caused by Staph aureus in India? Second question is, when to add MRSA cover in patients getting treated for pneumonia in India? And third question is, which is the better MRSA drug for pneumonia, vancomycin, linezolid, or clindamycin?
Okay, difficult questions. The answer to the first question is, I don't know what percentage would cause of pneumonia in India would be due to MRSA. All I can say is that it would have to be in the single digits. It cannot be in 2 figures. Even abroad, only about 9% of pneumonia is caused by pneumococcus, let alone staph, and a fraction of that would be MRSA. So single digits, probably less than 5%, but that's a guess. The second question is, you said, when do you suspect, right? What is the question? When would you suspect? So basically, anybody who has had previous skin and soft tissue infections, was had previous infections with MRSA, anybody who has a pneumococcal or something that necrotizes, anybody who is in the ICU in septic shock. So if you're really sick, please give MRSA coverage. It's better to over-treat these patients rather than under-treat them.
And which drug to choose?
Which drug to choose? Well, you could use vancomycin or linezolid head-to-head in hospital-acquired pneumonia. Linezolid was somewhat better. Community-acquired pneumonia, both are probably equivalent. Linezolid may give you the advantage of shutting off of PVL toxin production, which these staphylococci often produce. My personal preference is linezolid, but vancomycin is fine.
Okay, sir. The next question is clarithromycin superior to azithromycin in treating pneumonia on an OP basis?
No, there is no reason to prefer one macrolide over the other. Azithromycin has some pharmacokinetic advantages. You can dose it once a day and perhaps for a shorter period of time, but both macrolides are equivalent.
Next is in the background of COPD, do we need to give empirical dual Pseudomonas cover for community-acquired pneumonia?
In the background of COPD, you have to actually see, is it truly COPD or is it structural lung disease? When you say COPD, for instance, asthma, those patients are treated just like other immune-competent hosts. But if you have structural lung disease, like say bronchiectasis, then Pseudomonas is a consideration. These patients, the question is, do they have COPD exacerbation or they have a pneumonia on top of the COPD? So fluoroquinolones, if it is sensitive, would be an optimum agent. If they're more severely ill in the ICU, you would need an anti-pseudomonal beta-lactam.
Okay. Another interesting question is it advisable to regularly screen for MRSA in respiratory ICU?
Definitely not. MRSA is not as common in India as in the West. Most ICUs would get colonized by gram negatives rather than MRSA.
Another question is, sir, I'll just take a couple of more. What is the difference between PCV and PPSV23 vaccine? If you'd like, I think
okay, pneumococcal conjugate vaccine is PCV. It has coverage against 13 serotypes. There is a new one on the horizon, which is FDA approved abroad, PCV20, which covers 20 serotypes. It is conjugated to a protein, so it stimulates the T cell wing of the immune system as well. It's much more immunogenic, but it covers fewer serotypes. The classical one we have is the PPSV23, pneumococcal polysaccharide vaccine, covers 23 serotypes, but it only gives you humoral immunity. So it's not a very effective vaccine. So that's the basic difference. What we recommend is about the age of 65, you give a conjugate vaccine first and follow it up with a polysaccharide vaccine later.
Sir, what are the antibiotics of choice for COPD exacerbation?
COPD exacerbation, once again, try to decide whether there is structural lung disease or is it functional lung disease, just asthma, etc., or is this bronchiectasis? If it is asthma or smoking-related COPD, anything, amoxiclav, azithro, etc. Often these patients need bronchodilators rather than antibiotics. Only if they are severely ill do antibiotics really work. Structural lung disease, some form of pseudomonal cover, such as, say, fluoroquinolone.
Just last one, sir. What is your threshold for starting antifungals in high serum galactomannan in a pneumonia not responding to antibiotics?
So the most important factor to decide whether you need to introduce antifungals is the host. So I don't really worry about the galactomannan if the host is appropriate. For instance, if it's a profound neutropenia, an ANC less than 100 for, say, more than 10 days, non-responding pneumonia, a CT scan compatible, I wouldn't worry about the galactomannan. I would offer that patient antifungal therapy. On the other hand, if this is an immune competent host, a young patient with a non-resolving pneumonia, high galactomannan, perhaps that's a false positive. So the most important thing is the host rather than the number.
Thank you, sir. Thank you so much. And so, thank you once again for sparing your time to POTCIT's PG Education Subcommittee. I hope that everyone would have learned a lot from you for your lecture today, sir. Thank you so much, sir. Can I move ahead with the quiz, Dr. Vidya?
Yeah, I think, yes, we can.
So before I project the quiz questions, I would like to just announce that we will accept answers in the form of in the chat box. Please, there will be 3 questions. Most of them, the questions, answers, to try to put them in the as a bunch, all the 3 at one go. Don't answer one by one. So, and listen to the question. The answers are very specific. Other thing is that please do not unmute yourself and start announcing the answers. Please put them in the chat box itself. And request is that only postgraduate students or students, junior residents who have completed their MBBS should take part in the quiz. Senior guys, if they are attending, please excuse us for this. I will just read the questions and wait for 15 seconds after each question. And then subsequently, after I finish all the 3 questions, I will wait for another 30 seconds. Then we will start discussing the answers. So question 1 is there in the flyer. 70-year-old gentleman who is diabetic and COPD for last 20 and 15 years respectively. He has come to the ER with fever for 2 days along with cough and mild breathlessness. He had a similar episode 2 months back, but the records of the treatment were not available. On examination, he is having normal vitals with mild hypoxia, SpO2 of 89% on room air. Chest auscultation revealed bilateral V's with inspiratory rails in the right subscapular area. Chest X-ray is shown in the slide. Question is, what will be your antibiotic or antibiotics of choice for this patient? Next question is 60-year-old gentleman who is not known to have comorbidity, but he is obese. He had cough and running nose for the last 4 days. Now he has come with acute onset right-sided pruritic type chest pain for the last 1 day. He is febrile on examination. Rest of the exam is okay, except for tachycardia. Clinical diagnosis of community-acquired pneumonia was made by the resident, and he was started on piperacillin, tazobactam, and azithromycin. Day 3 of admission is slightly better, but cultures are negative. Urine pneumococcal antigen is positive. Sputum result has also come. The Gram staining showing few pus cells and plenty of epithelial cells. Culture has grown E. coli. This is the culture report. Question is, prescribe new antibiotics or antibiotics for this patient.
No.
Or third question is a 45-year-old male who is having acute myeloid leukemia. He has undergone induction chemotherapy with cytarabine and daunorubicin, which had not led to remission. He is given another set of chemotherapy, FLAG, fludarabine, and high-dose cytarabine and venetoclax. He is now neutropenic for last more than 30 days. He has started developing fever for last 2 days and a left-sided chest pain. This is the CT scan of the chest. Question is, name the radiological abnormality. I will move on to the answers. So case 1 is an elderly patient with community-acquired pneumonia who requires admission in the ward. He had antibiotic exposure and he has got COPD also. So probably he has risk factors for Pseudomonas aeruginosa and other enteric gram-negatives also. So antibiotics of choice is piperacillin tazobactam or other BLBLIs in combination with a macrolide or a doxycycline. Second one is an adult patient who's presented with CAP after respiratory viral illness. Pneumococcal antigen is a very specific test, as discussed by Sir. Diagnosis is CAP with Streptococcus pneumoniae, and sputum culture can be ignored here because the quality of the sputum was very bad, and anyway it's not recommended. Drug of choice is amoxicillin, plain amoxicillin, or ceftriaxone as an alternate option. For case 3, it's a reverse halo sign. Reverse halo sign is a focal rounded area of ground glass opacity surrounded by the crescent of consolidation. It is typically or more famously known for mucormycosis, but as you can see, it's basically an evolving cavity. So any cavitatory pneumonia or any cause of cavitatory pneumonia can present with reverse halo sign. Shall I disclose of the this one, winners?
Yeah, we can.